Hello, welcome again to the DNA Biometrics channel. So today we are looking at the microorganism known as Staphylococci. So firstly, Staphylococci are known as facultative anaerobes. They are gram-positive and occur in grape-like clusters and are catalase positive. They are major components of the normal flora of skin and nose in all people. So one organism we will look at today is Staphylococcus aureus. This is one of the most common causes of opportunistic nosocomial and community infections. These infections include pneumonia, osteomyelitis, septic arthritis, bacteremia, endocarditis, abscesses, boils, and other skin infections. So Staphylococcus aureus is famous because of the increased incidence of methicillin-resistant Staphylococcus aureus infections. So looking at the pathogenesis, firstly, food poisoning. So Staph aureus produces a number of toxins, of which the enterotoxins A, B, C, and D cause food poisoning. About a third of half of S. aureus strains produce enterotoxins, which are heat stable and survive cooking, boiling for 30 minutes. They are also resistant to proteolysis by intestinal proteases. Food becomes contaminated with the organism from human contact, grows and produces enterotoxin. The organism does not infect the patient on ingestion of contaminated food. Rather, the pre-existing toxin causes the symptoms, which include vomiting, nausea, diarrhea, which is watery or non-bloody, leading to dehydration, abdominal pain. There's not usually fever. Because only the toxin is involved, onset of symptoms occur within a few hours and recovery occurs within a day. Antibiotic treatment is not indicated because the bacteria are not directly involved in causing the symptoms and may have anyway been killed by cooking. Enterotoxins are known as superantigens that lead to cytokine production, T cell activation, neutrophil infiltration with loss of small intestine brush border cells. The release of inflammatory mediators may be the cause of the characteristic S. aureus food poisoning associated vomiting. So looking at enterocolitis, these are the symptoms are similar to food poisoning. So you get watery, diarrhea, and abdominal pain, but also include fever. They are also produced by enterotoxin A and leukotoxin. The cause and the treatment of patients with broad-spectrum antibiotics that allow S. aureus, which infects almost everyone, to grow in the intestine in preference to the normal bacterial flora. The bacteria can be detected in fecal samples. Another topic I want to touch upon in regards to S. aureus is toxic shock syndrome. This is caused by infection with strains of S. aureus that produces toxic shock syndrome toxin. So it can be associated with a wound in which the bacteria multiply rapidly but become particularly prominent to the public. And this was in the previous years when the S. aureus infection was found to cause toxic shock syndrome that was seen after the use of certain tampons. The bacteria were able to divide rapidly within the tampon. They do not disseminate but remain in the vagina. However, the toxin does disseminate and is responsible for clinical features. The symptoms include fever, macular erythematosus rash, desquamation, vomiting, and diarrhea. Toxic shock syndrome has the properties of a superantigen, resulting in the production of cytokines, vascular leak, and cell toxicity. This results in hypovolemic shock and death as a result of multi-organ failure. Before the cause of toxic shock syndrome was discovered, the mortality rate was high but is now around 5%. There can be recurring disease if the patient is not treated with the appropriate antibiotic. Toxic shock syndrome toxin is involved in most menstruation-associated toxic shock syndrome, whereas enterotoxin B is involved in many non-menstruation-associated cases of toxic shock syndrome. So moving on to scalded skin syndrome, such as Ritto disease, Pemphigus neonaturatum, and bullous impetigo. So a minority of S. aureus strains produce exfoliative toxins A and B, and either toxin can cause scalded skin syndrome or bullous impetigo in babies and young children, but rarely in adults. These toxins are serine proteases that can digest, among other proteins, some of the proteins located in desmosomes, the structures that link epithelial cells together. For example, the desmosomal protein called desmoglin is digested between the cells of the stratum granulosum epidermis. The process often results as a result of the formation of protective neutralizing antibodies. Exfoliative toxins are also superantigens. Bullous impetigo is a mild form of S. aureus disease that usually occurs in newborn infants and young children. It is manifested by a large flaccid bullae and attributed to S. aureus strains belonging to the phage group 2, capable of producing exfoliative toxins A and B that separate the stratum corneum from the rest of the epidermis. The more common and milder form of disease, representing about 10% of all cases of impetigo, differs from non-bullous impetigo in that the vesicles enlarge into flaccid bullae before rupturing. The exposed skin surface is at first moist and red, resembling a small burn. A thin light brown varnish-like crust then develops. Unlike the situation with scalded skin syndrome, bacteria can be cultured from the fluid of the bullae and the Kolsky sign is absent. The more severe form of disease of greater skin involvement caused by the same staphylococcal strains is known as the staphylococcal scalded skin syndrome. This also usually affects younger children. The disease starts with local periomal erythema that spreads over the whole body and progresses to widespread flaccid bullae that rupture, causing exfoliation of the skin that resembles an extensive third-degree burn. There are no organisms that can be cultured from the fluid of the bullae, indicating that the bullae are caused by the toxin and not the bacteria themselves. Before the bullae form, slight pressure on the apparently normal epidermis may separate it at the basal layer. It may be rubbed off and pressed with a sliding motion. This is known as the Kolsky sign. This form of disease can occur in epidemic form in nurseries, where it is known as pemphigus neonatum or Ritter's disease. Fever and other systemic symptoms are usually absent in a more localized form of disease, but are present in patients with the staphylococcal scalded skin syndrome. The localized bullous impetigo is self-limited due to the formation of neutralizing antitoxin antibodies, and this is also usually the case of staphylococcal scalded skin syndrome. However, SSCS carries a significant mortality rate of 5% that results from secondary bacterial infections in the area where the skin surface has been lost. Staphylococcal scalded skin syndrome in adults is rare and is usually associated with immunosuppression or kidney disease. In this case, mortality can be as high as half of the patients. So, S. aureus causes a number of different diseases entities associated with the production of certain exotoxins. In addition to these disease-specific exotoxins, other cell-lytic exotoxins, alpha, beta, gamma, delta, and leukocidins, can be produced. These are also called cytotoxins because they cause cytolysis as a result of plasma membrane damage. This leads to tissue destruction as a result of lysosomal enzyme release. So firstly, looking at alpha toxin, this singular polypeptide toxin interacts directly with the plasma membrane of many cells, embedding itself in a lipid bilayer and forming pores that permits ions to pass in and out of the cell. For example, potassium ions are lost quite often and sodium and calcium enter the cell. This leads to osmotolysis. Alpha toxin is made by most S. aureus strains. Beta toxin also damages cell membranes by degrading specific lipids, sphingomyelin and lysophosphatidylchlorine. The toxin is a sphingomyelin C and is also a single polypeptide that is made by most S. aureus strains. It appears that a degree of toxicity depends on the concentration of these lipids in the cell, both of which are found primarily in the outer monolayer of the plasma membrane bilayer. Gamma toxins and pantomvaline leukocidin consist of two polypeptide chains, an S chain and an F chain, which together form pores in the plasma membranes of susceptible cells. 3 S chains and 2 F chains have been found which can combine to form a number of different toxins that are cytolytic to neutrophils and macrophages. The gamma toxins are also hemolytic, whereas PV leukocidin is not. The gamma toxins are also made by most S. aureus strains, whereas PV leukocidin is made only by minority of strains. It has been particularly associated with violent methicillin resistance S. aureus infections. The next one we're going to look at is delta toxin. This is a small protein that is cytotoxic to many cells. It can act like a detergent, damaging cell membrane bilayers, resulting in cytolysis. So other diseases caused by S. aureus includes respiratory disease, bacteremia, endocarditis, urinary tract infections, and dissemination also occurs to other parts of the bodies. So firstly, looking at aspiration, pneumonia can result from an entry of oral secretion into the lungs. The bacteria can cause local abscesses and infiltrates. The disease is found in the very young, the very old, and patients with pulmonary disease. It can also be spread of blood-borne organisms in the lungs, causing hematogenic pneumonia. People with MRSA can get necrotizing pneumonia, which has a very high fatality rate. Emphysema is an accumulation of pus in the cavity of the body, such as the lungs, and is sometimes seen in pneumonia patients. Many of these cases are a result of S. aureus infections. So for bacteremia, S. aureus is found in the skin of most people and can enter the body in wounds. Many cases are nosocomial and result from surgery or catheter use. The bacteria can disseminate throughout the body. Looking at endocarditis, this is an inflammation of the endocardium with the inner layer of the heart and usually involves the heart valves native of prosthetic valves, and it can have a high mortality rate. Complicated urinary tract infections can also occur in specific clinical settings. Renal abscess can result from hematologic seeding of the renal cortex, usually due to S. aureus, or from the ascending infection leading to severe pyelonephritis, which is usually due to gram-negative rods. So, as I mentioned earlier with dissemination, S. aureus bacteremia can also disseminate via the bloodstream to other parts of the body, causing disease. Such sites include bone, giving rise to S. aureus osteomyelitis, resulting in pain, fever, and sometimes a Brody abscess and septic arthritis. So, skin disease can also occur, known as folliculitis. So, this affects nearly everyone at one time or another, was usually self-limited. So it can also evolve into larger lesions known as furuncles or tubercles. So S. aureus is the usual cause of folliculitis in non-immunocompromised patients. The infection probably arising from prior nasal colonization by this bacterium. So the term furunculosis refers to multiple boils or frequent recurrences. Carbuncles are more expensive and difficult to treat lesions that often require surgical intervention. Skin abscesses, although similar to carbuncles histologically, are usually deeper infections and not originate in the follicles. So there are predisposing factors to recurrent furuncles, including obesity, corticosteroid therapy, neutrophil function disorders, and diabetes mellitus. Immunoglobulin levels are usually normal in patients with furunculosis. So S. aureus stains secrete a number of tissue-degrading enzymes that can result in tissue damage. These include lipases, nucleases, hyaluronidase, coagulase, and plasmin. One form of coagulase is bound to the S. aureus surface and converts fibrinogen to fibrin. This insoluble protein causes the bacteria to agitate. The other coagulate is secreted and combines with coagulase reacting factor in the serum, resulting in the formation of staphylothrombin. That, like normal thrombin, also forms insoluble fibrin. This can also be antiphagocytic. As well as this, there is also protectionist phagocytosis. So S. aureus stains produce other proteins involved in pathogenesis. For example, these bacteria have two mechanisms that protect them against phagocytosis by polymorphonucleosides and other phagocytic cells. Although the bacteria are opsonized by proteins in serum, the capsule and slime layer protect the cells against phagocytosis. Protein A is found on the surfaces of most S. aureus stains, and it binds to immunoglobulin G and complement, blocking Fc and complement receptors, and is therefore antiphagocytic. Sorry, in a bit of a bust there. So for identifying S. aureus, so this is beta hemolytic or sheep blood agar. It ferments mannitol, is often golden pigmented, and that's why it's got the name aureus. It's coagulase positive, so if you find a test or ran on it, you'll see that it's coagulase positive. Presence of protein A, and in reference laboratories, phage typing is used for this. So this is an interesting one that gained quite a lot of notoriety, and this is known as MRSA, methicillin-resistant S. aureus. This is any strain of S. aureus that has developed resistance to beta-lactam antibiotics such as penicillins and cephalosporins. This results from the production of a phage-coated penicillinase that degrades beta-lactam antibiotics. Some strains also have modified penicillin-binding proteins. Many healthy people carry MRSA asymptomatically. Patients with compromised immune systems are at a significantly greater risk of symptomatic infections. Healthy people may have a simple topical skin infection, but in some people, MRSA can progress rapidly within a day or two of initial topical symptoms. In these patients, after about 72 hours, MRSA may invade tissues and become resistant to treatment. The majority of community-associated MRSA infections are localized to skin and soft tissue and usually can be treated effectively, but some strains exhibit enhanced virulence and spread into the tissues, causing illness much more severe than traditional nosocomial MRSA infections. At first, MRSA is characterized by small red pimples and there may be a fever and a rash. As the infection progresses over a period of a few days, the pimples increase in size and become more painful. Eventually, these produce deep pus-filled boils. The infection can disseminate throughout the body, causing sepsis, and vital organs may be affected. This can lead to toxic shock syndrome and necrotizing pneumonia, sometimes referred to as flesh-eating pneumonia. In hospitals, there can be surgical site infections. So, diagnosis can be done by growth of the organism in a laboratory, and there are more rapid tests such as quantitative PCR. So, I mentioned that before in identification slides, what other tests you can use, etc. So, the sheep blood agar, the beta hemolysis, etc. Treatment: intravenous vancomycin and tiotroplanin are used to treat MRSA, but some new MRSA strains are resistant to these antibiotics. Daptomycin is also used. So these are quite common antibiotics used in these infections: vancomycin, tiotroplanin, and daptomycin. Moving on to another type of Staphylococcus. So this is now Staph epidermis. This is a major component of the skin floral and is commonly a contaminant of cultural laboratories. It is less common cause of opportunistic infections, but it's still significant. Normally, if these infections are nosocomial, the bacteria form biofilms or catheters, stunts, artificial heart valves, and other surgical devices and cause endocarditis and sepsis. The formation of biofilms is important in the virulence of the bacteria. It is likely that bacteria bind blood proteins and extracellular matrix proteins to the surface. The bacteria also produce a sulfated polysaccharide extracellular coat called a polysaccharide intracellular adhesion. Other bacteria bind to the surface of the coat, making a multi-layer biofilm. The cells within the biofilm become partially metabolically inactive, and this, as well as the difficulty in penetrating the biofilm of antibiotics, means it's difficult to treat Staph epidermis. Staph epidermis is also antibiotic resistant, as well as to including penicillin, amoxicillin, and methicillin. Since antibiotics are largely ineffective in clearing biofilms, the usual treatment is to change the infected medical device. The drug of choice is usually vancomycin, to which rifampin or aminoglycosylate is added. With regards with the identification, it does not ferment mannitol. It is non-pigmented and it is coagulase negative, and it is non-hemolytic on growth on sheep blood agar. Staphylococcus saprophyticus. So this organism is a gram-positive coagulase negative bacterium and a significant cause of urinary tract infections, usually in young women who are sexually active. It is usually not differentiated from S. epidermis clinically. So it occurs in the normal flora of the female genital tract and perineum and in females in the age 17 to 27. It is the second most common cause of urinary tract infection. Symptoms include dysuria, pyuria. Sexual activity increases the risk of infection of the urinary tract because bacteria are transferred from the vagina and perineum into urethra. Most cases occur within a day of sexual intercourse, and the infection is sometimes known as honeymoon cystitis. So S. saprophyticus has the capacity to selectively adhere to the human urothelium. The adhesion for S. saprophyticus is a lactosamine structure, and it produces no exotoxins. That's just a few examples I've spoken today about, such as MRSA, Staph aureus, Staph epidermis, and Staph saprophyticus. There was another one I wanted to add in, but the video would get a bit too long. I don't. If you're listening, you're getting tired. I don't think you want to listen to the other one. Another interesting one is what I would look at is Staphylococcus pneumoniae. Have a look at that one as well, yeah. In the future, maybe I'll make a video about that as well. So thanks very much for tuning in, and see you later.